two, one. Please start, sir. We are live.
Good
Okay.
evening, everyone. I welcome you all for today's webinar on Oncology Symposium 2024. With immense pleasure, I would like to invite Dr. Kapil Goel, who is consultant medical oncologist at Rajiv Gandhi Cancer Institute, Delhi. For the welcome and introductory note, the stage is all yours, sir.
Thanks a lot, organizers, for inviting me to hold this symposium. So, as we all know, that carcinoma lung has been undergoing a paradigm shift in the treatment strategy, specifically with the use of new molecules coming up, the lots of driver mutation testing which is available now, and lots of targeted therapy that are coming in big picture. And now we have good quality data to support the use of targeted therapy in the first line agent. So to discuss all the recent advances, so we have organized this symposium 2024. So it is my honor that I will be discussing the lung cancer treatment with various prominent oncologists of the Delhi NCR. So in this sequence, we have Dr. Rakesh Sharma, who is a consultant oncology in Max Hospital Saket. Then we have Dr. Nitin SG, who will be having a talk. He is a medical oncology consultant in CK Birla Hospital, New Delhi. And last, we have a talk by Dr. Manish Sharma, who is a consultant in medical oncology in Action Cancer Hospital. And lastly, I will be taking a talk about osimertinib. My introduction has already been given. So I hope that we can learn from each other after the discussion, and we will be taking question after each and every session. So in this sequence, first of all, I would like to invite Dr. Rakesh Sharma. Dr. Rakesh Sharma will be giving a talk about the role of diagnosis and biopsy in NSCLC and the basic biomolecular studies. Over to you, Dr. Rakesh.
Thank you, Dr. Kapil. So I will be discussing about the molecular biomarker testing in lung cancer. So as we all know, lung cancer is a forefront leader of precision oncology, and with the availability of molecular biomarkers, the management of lung cancer, particularly stage 4 disease, has been revolutionized with survival outcomes ranging from for in terms of 3 to 5 years, which previously was considered a deadly disease. So this is the general schema of my presentation. I will be discussing briefly about the epidemiology, biomarkers testing, and evolution of biomarker testing and key takeaways. So the burden of disease in India, as per Globocare 2020, approximately 72,000 new cases were diagnosed, out of which 52,000 approximately were male patients. So the burden is huge. It is fourth most common cancer overall, second most in male, and fourth leading cause of cancer-related mortality. So this is the general pie chart, which highlights the prevalence of various mutation in lung cancer, or which out of which KRAS is most common in Western world. However, in Indian subcontinent, EGFR is more common, followed by ALK mutation, ROS, MET, HER2, MET exon 14 skipping, EGFR exon 20 insertion, and so on. So what is the importance of biomarker testing in non-small cell lung cancer? So with this Kaplan-Meier curve, we can clearly see the survival in targeted in molecular marker driven cancer is superior to patients who lack driver mutations. So we can see that it is around 18.6 months versus 11 months. So this justifies the biomarker testing and directed treatment based on the mutation. So as per various guidelines, various mutations are recommended in frontline testing in metastatic disease. This recommendation has been changing ever since various mutations were approved. Nowadays, everyone is practicing comprehensive genomic profile with NGS, either Foundation 1, Garden 360, or Caris, whichever is available. Some Indian NGS are also available, but the recommended ones are uh, the FDA approved ones are Foundation 1, Garden 360, Caris. So what are the various methods to test mutations? So these can be done with either DNA-based sequencing with NGS, PCR, RNA sequencing, IHC testing. So DNA-based sequencing can detect almost every kind of mutation except for fusion kind for which RNA sequencing is preferred. IHC is basically used for ALK and ROS1. It is a sensitive but not a reliable marker to guide treatment. It has to be reconfirmed. But IHC is a reliable marker to detect PDL1 for which various platforms are available. Commonly used is DACU platform, although Ventana 263, SP263 is also commonly used. So evolution of biomarker testing in NSCLC. So previously the diagnosis was based on histology and we used to classify NSCLC in squamous cell and no, adenocarcinoma, which is supplemented by IHC. Nowadays, IHC is used for PDL1 testing, MMR testing, and further testing which are available nowadays are genomic profiling, which can be done with NGS, fish testing, PCR, and various other techniques. So biopsy, it is of paramount importance in establishing the diagnosis, which classify squamous versus adenocarcinoma. It can be obtained from primary site or metastatic site. Bone biopsy is usually not preferred, although it is a common metastatic site. So everyone is doing EGFR, ALK, BRAF, NTRK, RET, MET exon 14 skipping mutation in non-squamous NSCLC, although this can be done with NGS panel also. And along with that, PDL1 testing is recommended. So usual turnaround time with NGS is around 10 to 14 days. So a brief about circulating tumor DNA. This is now talk of the town in recent past, as it is less invasive, patient friendly, and turnaround time is less as compared to the tissue testing. So it can be used for establishing the diagnosis. The basis of this test is that some tumor DNA or cells are circulating in the blood, which can be detected by molecular techniques. Although this is not an approved modality, but this may become a technique for of preference in future. This has been used for monitoring response assessment and early relapse detection by MRD testing, particularly in colon cancer, but the role is still under evolution. Moving on. So it is a complementary test to tissue biopsy. It will not replace tissue biopsy entirely, but it will complement tissue biopsy in an SCLC in future. So it can be, I have highlighted this earlier also, it can be used to detect earlier responses which can be easily missed by imaging techniques. So in Tracer X study, about 24 patients were studied and MRD testing was done. So most of the relapses were in MRD positive disease, MRD positive patients, whereas recurrence were less common in MRD negative disease. So it can be a tool in the future to monitor the relapses at earlier stages, even before they are visible on imaging. So a brief about comparison about tumor tissue versus liquid biopsy. So liquid biopsy getting sample is very easy. About 10 ml blood sample is easy. It can be easily repeated without any inconvenience to the patient. Repeated biopsy is somewhat inconvenient to the patients. Biology, it correlates with histology and cellular phenotype in tumor tissue. Whereas in liquid biopsy, direct correlation between ctDNA and histology may not be possible. Sensitivity of tissue diagnosis is very high and lower sensitive techniques can be used. For liquid biopsy, very sensitive methods are required as circulating tumor DNA can be less than 0.1%. And tissue diagnostic methods are validated across the world, but liquid biopsy standardization is still under evolution. And tissue diagnostic modalities are the forefront to guide the treatment in metastatic NSCLC and for that matter every malignancy. But in liquid biopsy, the role is still under evolution. In future, it may help guiding treatment in various malignancies, but for now, tissue diagnostics should be the preferred modality. Liquid biopsy may be considered for MRD testing or supplementing tissue diagnosis. So advantages of NGS. So one advantage is that we can study multiple mutation in a single go. But and now previously the turnaround time used to be around 4 weeks. Now with various techniques, it has come down to around 2 to 3 weeks. But only hindering factor in NGS is the cost, followed by turnaround time. As compared to individual testing of EGFR Alcross, turnaround time is usually 5 to 7 days, but with NGS it is around 2 weeks. So techniques, this has been discussed previously. So these are the various mutations which are tested. This has also been discussed. We will move on to EGFR mutation in lung cancer. So to study EGFR, formalin fixed paraffin embedded sections from can be used of tissue obtained from various site of the tumor, and there is a good concordance of EGFR mutation in primary site and metastatic sites. Discordances are very rare. So this is recommended by various guidelines to test for EGFR, and there is nothing new about this. So what is the advantage of NGS over PCR to detect EGFR mutation? So according to various studies, about 45 to 50% of the EGFR exon 20 insertion mutation can be missed by PCR, which can be detected by NGS. So, and one out of this 17 most common EGFR exon 20 is a insertion mutation variant. Only 4 can be identified via PCR. So NGS has clearly advantage over PCR in terms of detecting various EGFR mutation. ALK rearrangement. So the preferred modality to detect ALK fusions are FISH, and false positivity rate is very low, about 0.1% with FISH. But IHC is easily available, less expensive. It is very widely adopted across various institutions, but it has to be reconfirmed. Similarly, for ROS1 rearrangement, preferred modality is also FISH, although it can be detected with IHC, but it has to be reconfirmed with second modality, that is FISH. KRAS mutation. KRAS is a common mutation in lung cancer. Approximately, it is present in 30% of the cancers, and it can be detected with multi-gene NGS panel. Recently, various drugs were tested in KRAS mutant, in various types of the cancer, and sotorasib and adagrasib has been tested in NSCLC, although approval for sotorasib has been rejected, if I am not wrong, and it is a common mutation for development of resistance to various treatment. BRAF mutation is present in about 1 to 5% of the patients, most commonly adenocarcinoma. It can be detected with PCR, IHC, though not commonly recommended, but NGS is generally the preferred modality. And now we have treatment approved for the BRAF V600E mutation, that is the combination of dabrafenib plus trametinib. c-MET receptor tyrosine kinase mutation and MET exon 14 skipping mutation. So it is present in approximately 3 to 4% of non-squamous NSCLC and 20 to 30% of the sarcomatoid variant. And majority of the mutation can be detected with DNA NGS, but RNA NGS has more sensitivity for this kind of mutation, and it should be reconfirmed with RNA-based NGS. So IHC fish for detection of MET exon 14 mutations are not recommended. DNA, it is easily available, DNA-based PCR and DNA-based NGS are easily available, but they can miss this mutation. It has to be tested with RNA-based NGS, as it is most sensitive for this mutation. RET mutation, it is present in about 1 to 2% of NSCLC, and majority of the RET fusion can be detected with DNA NGS, but sensitivity of RNA NGS is more as compared to DNA NGS. So this is a repetition of the same thing. Anti-RK fusions, there are various options to detect anti-RK fusions. RNA NGS is the most sensitive modality, and it can be either done in frontline setting or it can be repeated reflexly, as the prevalence of this mutation is not that very high in lung cancer. HER2 mutation, these are present in about 3 to 5% of the cases, mostly are exon 20 in frame insertions. These are mutually exclusive kind of mutation and mostly seen in never smoker. And these mutations tend to have poorer outcome as compared to other subtypes of the lung cancer. And these are detected with NGS, DNA-based NGS. Overexpression of HER2 can be detected with IHC, which is seen in around 59% of the cases. So this is the general algorithm as per the mutation. This is the general algorithm for management of NSCLC, which is driven by molecular biomarker. So this is the discussion of the next coming talks, and I will skip this. So PDL1 overexpression, there are various platform available, which can be DACO22C3, Ventana SP263, SP142, 288. Commonly used platform is DACO, and it is a companion kit for pembrolizumab, and various other platforms are complementary to various molecules. Although PDL1 is a sole biomarker available to guide immunotherapy, but it is not a perfect biomarker, as we have seen that patients with PDL1 high may not respond to immunotherapy, or PDL1 negative tumors may respond to immunotherapy. But for now, we have this marker available in our arsenal, and we have to rely on this, although it is not a perfect biomarker. Other biomarkers which were previously used are TMBs, it is still used, but there is conflicting correlation. MSI high MMR, it is not of much relevance in lung cancer setting. LAG3 is possibly related to resistance to immunotherapy. It is under study now. So in conclusion, biomarker testing should be recommended in every lung cancer cases, particularly in stage 4 disease. Multidisciplinary meetings help in better understanding of sample and test requirements. Samples should contain adequate tumor tissue, at least 10%, to prevent delay in processing. Ideal TAT should be within 2 weeks or less, 10 working days, and NGS should be the preferred modality for detecting various mutations in a single go. So these are the common mutations which are tested in daily routine practice: EGFR, ALCROS, BRAF, KRAS, RET, MET exon 14 skipping mutation, NTRK, MET, and HER2. So with this, I will conclude my talk. I will be happy to answer any questions. Thank you.
Uh, Thank you so much, Dr. Rakesh, for this enlightening talk. So there was certainly a lot to learn. So is there any questions? So Dr. Rakesh, I just had a small question. Suppose you order an NGS panel and you get a HER2 certain mutation. So do you still go for FISH or IHC testing to look for amplification and this, or just the NGS is good enough?
Actually, if we test, amplifications are better detected with either IHC or FISH, and mutations are better detected with NGS techniques. So I think both should be done, although the response rates with trastuzumab in lung cancer are not that great. Only
Mm-hmm.
drug has done some, which has some activity in HER2 mutated or amplified lung cancer is Enhertu, which is recommended in second or later line, if I'm not wrong. In first line, in this scenario, the preferred
No,
treatment
what
is.
I meant to say ki even if on NGS you get let's say negative report or say positive report, so do you still need to like suppose if you get a positive report, so that is obviously becomes an indication to use this. So do you still go for IHC and FISH to reconfirm, or is it enough to use trastuzumab? That is one. Second question, suppose you get a negative, so even so is it a possibility that IHC expression or amplification might have been missed and you might want to go for IHC, etc.
So,
again?
in my slide, I have highlighted IH amplification of HER2 is more common, approximately 59% of the cases. But the risk, uh, I think both should be done. Mutations in HER2 cannot be detected with IHC or FISH.
Actually, can I add something?
Yeah, yeah.
Yeah, sure.
Yeah, actually, TDXD approval by FDA was basically for HER2 exon 20 insertion mutations.
Yes,
Classically, जो approval है, so that can be identified only by NGS or PCR.
yes,
So
that can
IHC
be.
can be used at later line if you don't have any other options, but ideally we have to get NGS or
But I
PCR
don't think
based
there is a
answers.
treatment implication, even if in HER2 amplified, the responses with addition of trastuzumab are not that great
Not that great.
as
So
compared to
mutation
breast
should be
cancer.
there ideally.
Yes, mutation should be the priority in lung cancer rather than amplification.
Right. So actually, when we are when we the NGS and PCR were actually not that commonly available, so there was no guideline to test for IHC. So I think Dr. Rakesh is right in this regard. We are not chasing the protein expression. However, somewhere I read that NGS can actually detect amplification a lot. So copy number variation report that we get through NGS. So it includes, and sometimes it is like mutually exclusive. If you've gotten a mutation, then it's certain that there will not be an amplification and vice versa. So, regardless, obviously, the treatment of choice remain TDX. If it is not available, then we try to give something of pertuzumab or trastuzumab or maybe TDM1, but then responses will actually be poor. Is there any other question from Dr. Rakesh? So thank you so much, Dr. Rakesh, for your talk. So for next, I would like to invite Dr. Nitin Esri. Dr. Nitin Esri has recently joined as consultant medical oncology in CK Birla Hospital, Punjabi Bagh, New Delhi. Dr. Nitin will be talking about current management algorithm in management of metastatic NSCLC. Over to you, Dr. Nitin.
Is my slide visible?
Your your desktop is visible.
You can't see the current lung cancer. The slide is not visible.
No, slides are not visible. Yeah, now it's visible. Hello. Dr. Nitin just got disconnected. He's trying to reconnect in a minute. Oh, okay. Welcome back, Dr. Nitin.
Are the slides visible now?
No, they're not yet visible.
Can we play from my
Can
end?
organizer share
Yeah.
the slide and Dr. Nitin will just read out?
What about now?
Now it's visible. It's visible now.
Yeah.
Please go
Very
ahead.
sorry for good evening, all. I'm very sorry for the delay.
No worries, no
For
worries,
the
no worries.
technical error. So I'll be talking about current lung cancer management, what physician needs to know. To begin with, we know that the lung cancer constitute around second most common cancer all over the world. This was a Globocan 2020 data in which lung cancer stands second, following breast cancer all over the world. And in India, it constitutes fourth most common cancer in with respect to incidence as well as with respect to mortality. Only 14% of lung cancer in India are diagnosed at an early stage. Mostly the patients with lung cancer presents with vague symptoms to physicians. And it's very important that the physician should know how to pick and who to be evaluated for the lung cancer. And in India, most of the lung cancers usually present at a very late stage. Around 44% of lung cancers among males present with distant metastasis, while 47% presents with distant metastasis in females. In comparison to breast cancer, which is often presented at an early stage, usually 57% are presented at a locoregional stage itself. So, will our early detection of lung cancer does that affect survival? So, yeah, many studies have been conducted over the years. We have seen that those patients who are detected at an early stage, 92% survival is seen in stage 1, and they can be treated curatively with surgery as well as radiotherapy. On the other hand, those patients who present at even stage 3 or stage 4, in stage 4 survival would stand to around 10%, and even stage 3, even with intensive therapy, the survival is around 15 to 20% in case of lung cancer. What are the risk factors for lung cancer? We all know smoking is the most important risk factor. All forms of tobacco can add to the increased incidence of lung cancer. Secondhand smoke. Family history do add to increased risk. There are some studies have shown that genetic risk is also involved, especially with association to T790M mutations. Radon gas, asbestos, other pollutants, radiation, etc., can lead to increased risk of lung cancer. So majorly lung cancer is classified into two groups, non-small cell lung carcinoma as well as small cell lung carcinoma. 85% is constituted by non-small cell lung carcinoma, which include adenocarcinoma, squamous cell carcinoma, large cell carcinoma, and other mixed variants like adenosquamous as well as sarcomatoid variants. Small cell lung carcinoma constitute 10 to 15%. They are often presented at a very late stage, and with all treatment armamentarium, they usually are associated with very poor survival. So treatment is based mainly on the histopathology, whether it is small cell or non-small cell. So small cell lung carcinoma, as we said, it usually constitutes around 12 to 14%. Overall survival is less than 1 year in early stages, and even at early stages, it is usually around 1.5 to 1.5, maximum 1.5 to 2 years, and with late stages, it would be around 6 to 8 months. Advances in the treatment of small cell lung carcinoma, over the last around 30 to 40 years, the treatment doesn't have changed much in case of small cell lung carcinoma, except for the addition of pembrolizumab immunotherapy, which has actually changed the treatment armamentarium and has improved the survival. But still, the backbone is mainly platinum doublet, which was started in 1985, and still we follow that with cisplatin etoposide or carboplatin etoposide as the base backbone chemotherapy. And we later studies have shown irinotecan, topotecan also to be effective, but they're usually used at the relapse refractory setting. And even nivolumab has been approved in relapsed case in case of small cell lung carcinoma. And usually in locally advanced stages or in advanced stages, we usually give thoracic RT. In early stage also, we give CT RT. And if those patients who respond, we also give prophylactic cranial irradiation. So currently, in 2018, there was approval for atezolizumab based on IM power 133, where atezolizumab have shown to increase OS overall survival, in addition to carboplatin etoposide in treatment of small cell lung carcinoma, and later durvalumab was also approved based on Caspian trial. Non-small cell lung carcinoma constitute around 85%. The survival outcome of non-small cell carcinoma have markedly improved over the last 10 to 15 years because of the identification of various molecular markers as well as targeted therapy based on these molecular markers. So, adenocarcinoma, as Dr. Rakesh discussed, we have multiple targetable mutations which has to be tested in all cases of adenocarcinoma, which include ALK, HER2, BRAF, PIK3CA, AKT1, NRAS, ROS1, RET, KRAS, and EGFR. Squamous cell carcinoma, FGFR, PIK3CA are seen, but they are not yet approved therapy in treatment for squamous cell carcinoma. Advances in treatment of non-small cell lung carcinoma. Targeted therapy is the key towards treatment of non-small cell carcinoma. In cases where there is a molecular marker, we get a molecular marker positive for molecular markers. So initially, we have studies which shown response with EGFR inhibitors. Later came ALK inhibitors as well as ROS inhibitors, and we also have nowadays we also have RAS inhibitors and RET inhibitors in the armamentarium. So initially for ALK positive NCLC in 2011, there was approval for crizotinib, crizotinib, following which there was approval for erlotinib for EGFR positive non-small cell lung carcinoma, followed by geftinib, and then dabrafenib plus trametinib in BRAF positive non-small cell lung carcinoma, alectinib. So we have got three, mainly what we use are three categories of drugs. One is EGFR inhibitors, where there are first generation, second generation, and third generation. ALK inhibitors as well as ROS inhibitors, which are readily available throughout in our country as well for the treatment of lung cancer. And in NTRK positive non-small cell carcinoma, there is approval for entrectinib, as well as for MET, we have got capmatinib and RET selpercatinib. So multidisciplinary team involvement and discussion is very important in providing an efficient and treatment for the patient as well as for better outcomes. This should include pulmonologist, radiologist, as pathologist, a dedicated, ideally dedicated pulmonary radiologist, then medical oncologist, primary care physician, as well as cardiothoracic surgeon. Management of early localized non-small cell lung carcinoma. So early localized includes stage 1, 2, and stage 3A based on AJCC 8 TNM classification. Stage 1 and 2 are often limited to the lung and not involving mediastinum or distant sites. Stage 3 usually involves mediastinal lymph nodes. Goal in all these cases, early as well as localized stage, our intention of treatment is curative. So as we discussed, multidisciplinary team discussion is very important. So initial discussion based on pathologists, whatever markers are available, whether it is non-small cell and small cell lung carcinoma. And then there should be discussion amongst the surgical oncologist, medical oncologist, as well as the radiation oncologist, whether the disease is resectable or not. If the tumor is upfront resectable, it's always better to go for surgery upfront itself. And we have studies which have shown that in addition to adjuvant chemotherapy is often given. If margins are positive, adjuvant RT is also given. And in addition to that, in those tumors where there is a specific marker available, for example, if it is EGFR mutation positive, we can give adjuvant osimertinib for 3 years, as seen in ADORA. As well as we have adjuvant immunotherapy trials which have also shown improvement in survival post resection. On those patients who are upfront unresectable, there is a choice of induction chemo if we think that reduction in size can lead to resection later. But usually multi-stage N2 or N3 disease, we don't usually consider surgery even after induction. So in unresectable cases, we'll usually go for either CTRT or then we'll go for, if CTRT is also not possible, then we go for palliative intent therapy. Surgical resection, mostly we do lobectomy, pneumonectomy, or wedge resection, depending on the lung reserve that is remaining, as well as the tumor size and the location. Outcomes in early stage lung cancer, surgery is a primary treatment, as we all know, and adjuvant cisplatin therapy has been shown in LACE meta-analysis to have to improve survival. It was around 5% improvement in overall survival over 5 years. So what we follow right now is post-surgery, if margin is positive, we give adjuvant RT as well. And along with that, we give 4 cycles of adjuvant cisplatin, platinum doublet, cisplatin, paclitaxel. Now, adjuvant osimertinib, as I discussed earlier, the ADORA trial have shown that addition of osimertinib has got improvement in survival as well as decrease in recurrence rate. The first Kaplan-Meier curves shows the updated DFS data in the overall population where stage 1B, 2, and 3A were taken. And there was marked reduction, 73% reduction in the risk of recurrence. And we can see that median DFS also, the hazard ratio was 0.27, which is like magical, or what you say, it's something which we always expect in a major trial. And in stage 2 and 3A, specifically, also there were marked improvement with hazard ratio 0.23 and 77% reduction in the risk of recurrence. Management of unresectable locally advanced non-small cell lung carcinoma. When mediastinal lymph node involvement is detected, patients are classified as stage 3 disease. So this is the AJCC 8th edition classification. I'm not going to depth of it. We all know that stage 3A, 3B till 3A, we can consider surgery as an option, but 3B onwards, usually it is CT-RT, or if totally unresectable or RT is not feasible, then we go for palliative intent. Approach to management of unresectable stage 3 disease. As we discussed earlier, multiple disciplinary teams are involved, and definitely CTRT is considered as a standard of care, especially for stage 3 disease overall, if it is unresectable. And we usually give concurrent chemoradiation, and there was various studies, especially meta-analysis, have shown that concurrent chemoradiation is better than sequential chemoradiation with improvement in overall survival with respect to timing of radiation and chemotherapy. So survival rates, even with CRT and all the therapies, have remained lower. And post CRT, based on the specific trial, we have an approval for adjuvant durvalumab, which have shown to improve survival as well as decrease recurrence rate if it is given after CTRT. If we give at least 2 cycles of platinum doublet, and if there is no progression following that, we can give 1 year of adjuvant durvalumab, which was shown to improvement in EFS. There is significant, but after all these, the survival outcome of stage 3 disease has not improved markedly, and we need more trials and more studies to see better options, which are whatever is available. Now, management of metastatic non-small cell lung carcinoma. Around 60% of lung cancer patients are usually diagnosed at stage 4. And treatment goals usually includes improving the survival as well as improving the quality of life, and relieve the severe and debilitating symptoms as well as decrease the side effects. So management of metastatic non-small cell lung carcinoma has markedly improved with the identification of molecular markers as well as availability of various targeted therapies. So targeted therapies, as we discussed earlier, include EGFR, ALK, and ROS1 inhibitors. And if PDL1 is available, then PDL1 present by IHC, then we can give checkpoint inhibitors as well. So with chemotherapy, average survival was meant to be around 8 to 12 months, and which has improved to around 38.6 months based on the FLORA trial, where osimertinib was compared with first generation TKI in EGFR mutated lung cancers. And it was found to have a marked improvement in progression-free survival as well as overall survival with addition of osimertinib. And checkpoint inhibitors based on Keynote 024, PDL1, those patients who have more than 50%, even single agent pembrolizumab was associated with an improvement in survival with an average overall survival of 30 months. So as we all know, targeted therapy in cancer is the new thing, and targeted therapy, which has been discussed in many platforms, and even Dr. Rakesh has discussed it very well. So it precisely identifies particular cancer target and attacks the target and stops the cancer growth and kills the cells. 50% of patients with lung cancer have some form of targetable mutations. So I'll go into deeper, I'll discuss in depth more about EGFR TKIs. So we have mainly 3 generations of EGFR TKIs. One is first generation, which includes erlotinib and gefitinib. They are often reversible, while second generation afatinib, dacomitinib, as well as third generation osimertinib are irreversible. All these have been found to be very effective in the treatment of metastatic lung cancer, but osimertinib was a game changer in the whole list. Osimertinib was the only drug which was found to have sensitivity against T79M mutation, for all other TKIs failed. And it is an irreversible target EGFR inhibitor. We usually covalent modification of the ATP binding site of EGFR and lead to its inhibition. So right now, for upfront treatment of either metastatic setting as well as in adjuvant setting, osimertinib is considered as the first line amongst the EGFR TKIs. Immunotherapy in cancer, the basic concept of immunotherapy in cancer is based on the PDL1, PD1 pathway, where PDL1 in the tumor cell, when locks with the PD1 in the lymphocyte, it lead to inhibition of the lymphocyte, so that lymphocyte goes into an adaptive phase. So if there is a PDL1 inhibitor which de-engages this locking between PDL1 and PD1, this lead to activation of T cells which can attack the tumor cell. So this is actually turning your own immunity against the cancer cell. That's what the basic concept of immunotherapy is. So in advanced non-small cell carcinoma, the studies have shown that those who have driver mutations, the immunotherapy doesn't work well, because that acts as the major pathway for the tumor proliferation. But in those patients who doesn't have a driver mutation, we can go ahead with immunotherapy in addition to chemotherapy. Those patients who have PD-L1 more than 50%, we have an option of pembrolizumab single agent, or we can give a combination of pembrolizumab. In case of adenocarcinoma, we give pemetrexed cisplatin, while in case of squamous cell carcinoma, we give Pacli carboplatin. And PD-L1 1 to 49%, we have pembrolizumab in combination with pemetrexed and cisplatin, or ABCP, quadruple regimen, including atezolizumab, bevacizumab, paclitaxel, and carboplatin, which is found to be better than bevacizumab or atezolizumab in combination with cisplatin. So to summarize, the overall 5-year survival in non-small cell lung carcinoma is between 10 to 15%, primarily because majority of patient presents in with locally advanced or distant metastatic stage. And this is very important, particularly in a country like ours, where the resources are poor and majority of people are not aware about the symptoms and diagnostic workup. Here, it is very important that the physician should be aware about these major symptoms of lung cancer, how to identify them, how to approach them in terms of identification, as well as how to refer them to whom for further managements. So fewer patients are usually diagnosed at an earlier stage. Also, as high as 30 to 60% of non-small cell carcinoma patients undergoing surgery eventually develop metastatic disease. Adjuvant osimertinib will provide a highly effective practice-changing treatment for patients with stage 1B, 2, and 3 EGFR non-small cell carcinoma after complete tumor resection. And recent update on ADORA trial have shown that marked improvement in overall survival. Keeping apart all the criticisms, ADORA trial have also shown that there is an overall survival benefit, and now osimertinib is considered as a standard of care for EGFR mutated non-small cell carcinoma, which has been resected. Largest unmet need in lung cancer can be categorized to areas like improving lung cancer literacy and awareness, increasing access to most innovative medicines, evolving how we think about patient support to reflect increased survivorship in lung cancer, enabling early diagnosis of lung cancer is the most important, where physicians' involvement is very important. For general physician partner in management of lung cancer, most of the lung cancer treatments are costly and time consuming. General physicians can help in counseling and decision making. They should have a high index of suspicion early and prompt diagnosis. Optimal referral to oncologist, pulmonologist, brief the patient about the importance of various tests and taking care during complications. Also during follow-up and recurrence. That's all. Thank you. So does anyone have any questions? Hello.
Thank you, Dr. Nitin, for this wonderful talk. So I just have a small question that we usually consider presence of driver mutation to be a resistant mechanism for immuno-oncology. So
Yes.
if a patient has EGFR, ROS, or ALK mutations, then we usually do not give immuno-oncology. So what is your practice regarding HER2, BRAF, and RET mutations? So that
far we
also
don't.
becomes a contraindication or not?
Yeah, so far we don't have any data. Actually, BRAF mutation, just study what was done in case of for approval of sotorasib, and as well as dabrafenib, vemurafenib, they didn't consider targeted mutations in their trials. So they were not. So there is no clear-cut guidelines about whether immunotherapy would work or not. So in those patients, we have if the general therapy is available, like anti-BRAF inhibitor or anti-RAS inhibitors are available, we can go ahead with it. If not, I would prefer giving chemotherapy, because considering in other EGFR, ALK, and ROS that immunotherapy doesn't usually work. So I would consider chemotherapy. Unless patient is very adamant about immunotherapy, otherwise I would consider chemotherapy and avoid immunotherapy as long as we have data.
What
We have
about
no
HER2?
data.
HER2?
HER2 actually, the HER2 was also not included. So HER2, if HER2 is present, then I would definitely go for TDXD if it is available. If not, still I would prefer giving chemotherapy only.
So chemotherapy is okay, but we were discussing about immunotherapy, whether it
That's what I'm telling. I wouldn't add immunotherapy because there is no clear-cut data on, because all these studies did not consider mutation positive cases were not included in these
So actually, we
trials.
do have data where it is said actually HER2 positivity potentiates the action of immuno-oncology. So if
Okay.
HER2 is present, actually immunotherapy can be given safely, and the response rates in immunotherapy in HER2 positive patient have been as good as HER2 negative patient.
Okay. I'm
So
not aware
that's just
about
I
that.
wanted to highlight that although
Okay.
EGFR, ALK, and ROS make the tumor resistant to immunotherapy, but HER2 is one segment where immunotherapy works, and it has been proven. Other question that I wanted to confirm is now that you must be aware about the FLORA2 data where they have used osimertinib along with
Mhm.
chemotherapy in the first line itself, and the PFS data seems to be promising,
Yeah.
increasing PFS from 18 months to 25 months. The OS data is still awaited. So how do you take that into your practice? Suppose tomorrow you get a patient is very much affordable. Say, doctor, whatever you want to do, just give me the best treatment available. So what is your approach going to be tomorrow?
My concern would be mainly the toxicity. If the patient is fit and very well I'm not expecting much toxicity in that patient, then I would definitely go with osimertinib in combination with chemotherapy, because there was earlier trial where geftinib has been compared included in chemotherapy. I mean, chemotherapy plus geftinib in first line has been tried, and they shown marked improvement in survival. But the
Yes,
toxicity
yes.
was much higher, that is not routinely used in our clinical practice. But in AIMS, we do give
We
geftinib
do
along
use
with
it. If
chemotherapy to young.
osimertinib patient is not affording for osimertinib, we do use then that
No,
situation.
no, but very rarely used, because mostly the patient can't tolerate. Most of the patients usually stop after 2 or 3 cycles, more maximum 2 cycles. That's what we have seen. So young patient, fit patient, definitely go prefer osimertinib plus chemo. And if osimertinib is not affording, then I would prefer geftinib plus chemo. But yeah, osimertinib plus chemo would be my first choice if patient is affording as well as fit.
Okay. Okay. So you don't want to wait for the OS data to mature. So suppose we
No,
say
no,
if the
no.
patient progresses and then you do not have anything else to offer at this point of time because you've
No, in
already
lung cancer,
exhausted the
mostly.
chemotherapy option.
But lung cancer, mostly it's our first hit is the best hit. I mean, we try to treat it as aggressive as possible so that we can get a longer survival. So I don't think that would be an issue, because there are multiple other वैसे भी chemotherapy doesn't have much, even platinum doublet doesn't have much response, or it's not going to improve the survival by years or anything. So we have second line docetaxel or other therapies are also available. So I would still prefer for a young patient, I would like to go hard at the first line itself.
You are up for osimertinib plus you don't want to wait for the
Yes,
OS
yes.
data and you are up for
No, no, no.
using a Flora
Yes,
2.
because that's what
I
I'm
think
telling. That's what I'm telling, because geftinib itself have shown an OS benefit. So I'm damn sure ki osimertinib
the
will
class effect, you
have.
are banking on the class effect that Gefitinib has
Yeah, yeah,
shown
yeah.
the benefits, so
Yes.
osimertinib is also likely to
So, and
show.
PFS is markedly improved. So most likely it should reflect in the OS data as well.
In the West data. Yeah, so sure. So I think by the end of this year or maybe by the early next year, we'll have more answers to this, and then the next strategy will be clarified. And also with this new Mariposa trial, the amivantamab, laratinib, all these big molecules also coming into the picture. I'm sure in the next few years, lot many newer molecules will become available, and treatment is going to be even more complex now. So, are there any other question with Dr. Nitin? So if there are none, so I think we can move ahead to the next session. So for the next session, I would like to invite Dr. Manish Sharma. Dr. Manish Sharma will be taking a class session on real world data of osimertinib. As we all know that the real world setting and trial setting can be quite different. So many a times the trial results do not get replicated in the real world. So what does the data say about osimertinib? Over to you, Dr. Manish.
Thank you, Dr. Kapil. I hope my slides are visible, right?
Yes, sir. Yes, sir. Your slides are visible and you're audible as well.
Yes, so I'll be taking through the real-world evidence in the osimertinib. It's the standard of care today in the management of non.
Can you just check your microphone? Your voice is very low. Volume is very low. So can you just be a little closer to the mouthpiece?
Okay. So in the patients with EGFR mutation positive, PFS improves after the treatment with EGFR TKI compared with that of cytotoxic chemotherapy. And the osimertinib is, as we know, is an irreversible third generation EGFR TKI that has demonstrated clinically meaningful benefit in terms of PFS and overall survival. Overall survival with osimertinib is 38.6 months versus 31.8 months which is the best treatment option to date, which is available. So coming on to the final survival analysis of this FLORA trial, which is a double-blind study design. Here, the stage 4 non-small cell lung cancer, adenocarcinoma, which were EGFR mutant, they were taken, and the stratification was between the exon 19 deletion or L858R and race, whether Asian or non-Asian. In these patients, they were randomized to osimertinib versus standard of care TKI, that is gefitinib or erlotinib. And then these patients, they were followed. The OS was a key secondary endpoint, and the final overall survival analysis planned for when the approximately 318 deaths they have occurred. So these were the baseline clinical characteristic, almost well balanced, and you can see the males, they were less represented as compared to the females, so 38% males and 54% females, median age being 64. Asians, they were more representative in this clinical trial. Then smoking status, 65% smoker, non-smoker, sorry, and 35% 35% smoker. CNS So this is the primary analysis. You can see the PFS, the graphs separating immediately within 3 months after starting of the treatment. And the PFS is 18.9 months versus 10.2 months, and the hazard ratio is 0.46. And there was no subgroup where the drug did not work. And this is the final overall analysis of overall survival. The overall survival was 38.8 months versus 31.8 months. The 3-year survival rate was 54% versus 44%. And these were the conclusion. There was a meaningful OS benefit, meaningful PFS benefit. The drug was well tolerated. This is the osimertinib as a best standard of care for the first-line treatment in the patients with EGFR mutant NSCLC. These are all the options for EGFR mutant NSCLC, which include erlotinib, gefitinib, dacomitinib, afatinib, and osimertinib. Osimertinib is preferred in category 1. Other are category 1, but they are not given the this preferred option. So coming on to the 3 real-world studies, one is FLOWER study, other is OCFACT, and third is Mykonos. So first I will discuss FLOWER study. So this is a brief introduction. Introduction says that the only 2 to 4% of the patients with cancer receive treatment within RCT, and thus it raises the issue of representativeness. We know that the real world data is very, very important because the RCTs, they are very stringently controlled, and the patient representativeness is not as good as that of the real world. So real world data becomes very, very important tool. And this is the key baseline features of this FLOWER study. Median age here was 68 months. So you see the older patients, they were also included. And 38% patients, they had brain metastasis at diagnosis. While stage 4A and 4B patient were 30% versus 90%. And the author also categorized about the number of the lesion and bone metastasis present at diagnosis or not, and what kind of baseline EGFR mutation existed in these patients. So these are the inclusion and exclusion criteria. We have already discussed: age more than 18 years, histological proven diagnosis of NSCLC, presence of EGFR mutation exon 18 or 21, locally advanced recurrent, and patient who have received this study drug in the clinical trial, they were excluded from the treatment. So coming on to the effectiveness, the patient with poor PS, comorbidity, and rare EGFR mutation and active brain metastasis they were included, which were excluded in the FLORA trial. So we know poor PS patient. Many of our patients, they come with poor performance status, and we usually offer them EGFR TK rather than abandoning them, as the trial did not include these patients. Many patients there with comorbidities and rare EGFR mutations, they were also present. And the outcome, they were similar to the published data, thus adding the consistency to the osimertinib efficacy. So no difference in PFS, TTD, and OS were noted in the elderly patient with comorbidity, and less common EGFR mutations. So this is the primary effectiveness assessment, and the median time to treatment discontinuation, you can see it was similar to that which we saw in the FLORA trial. And if the patient has symptoms or without symptoms, the median time to treatment discontinuation was more in those patients who did not have symptom at diagnosis. And similarly, median TTD was better in those patients who had less than 3 sites of bony metastasis compared to those who have more metastasis, more bony site metastasis. So the TTD appears to be more suitable endpoint to evaluate the treatment outcomes in the pragmatic real-world situation, and this was longer, 25.3 months, than the post-progression outcome analysis of the FLORA trial, which was 20.8 months, and better TTD was associated with fewer than 3 progressing site and isolated progression compared with the oligoid systemic progression. So this we have discussed poor treatment outcome with the patient with brain metastasis, presence of brain symptoms, and at least 3 metastatic sites at diagnosis. And you can see the hazard ratios also favored those patients who had less than 3 bony metastasis, less than 3 site of metastasis, and those patients who had brain metastasis and the symptoms. So complete remission was seen in none of the patients, and partial response was seen in 73% patients, stable disease 23% patient, and progressive disease in 4% patient. Similarly, if you see median PFS, it also followed the same trend as that of median TTD. It was better in those without brain metastasis. It was better in those without symptoms at diagnosis, and those who had less than 3 metastatic sites. So amongst the patient experiencing progressive disease, 47.7% patient underwent rebiopsy at progression, and the tissue rebiopsy, 14 cases, that is 66% patient, and liquid biopsy in 28.6% patient. Molecular analysis was performed in 61% patient, and MET amplification was noted in 4 patients. MET amplification, EGFR amplification noted in 1 patient, EGFR amplification in 1 patient, and HER2 new amplification in 1 patient. Safety data is very, very important, and there is something to show. The venous thromboembolism was much higher as that we see in the FLORA trial. It was 9.5% as compared to the placebo. And similarly, the rash, dry skin, paronychia, diarrhea, stomatitis, and ILD, they were more. So 9.5% patient, they had ILD. And grade 3/4 ILD was present in 2.4% patient. And grade 3/4 venous thromboembolism was present in 7.9% patient. So this is a remarkable thing which we should remember, which came out of this real world study. So 87% patient experienced adverse event. Venous thromboembolism was the most common, that is 7.9%. In the real world asterisk study, grade 3 pulmonary embolism accounted for 2% of the pre-treated patient receiving osimertinib, and no difference in the rate of VT was reported according to the age, PS, comorbidity, or tumor load. So no difference in survival outcome was observed according to age, comorbidity, and type of EGFR mutation. And osimertinib confirmed effectiveness and the efficacy in the real world scenario. Coming on to the second study, that is OCFECT study. This is the similar background which we saw in the last clinical study, the real world study. So inclusion criteria similar to that of the last study, EGFR mutant, NSCLC, and osimertinib as the initial treatment. And exclusion criteria were patient concurrently using other anti-cancer treatment, undergoing post-operative adjuvant chemotherapy, or receiving osimertinib as a second-line treatment. And these were baseline clinical characteristics of the patient. Median age was 71. So it was much more as compared to the FLORA trial. Males and female representation almost 34% versus 65% patient. And you can see here very, very important thing that 11% patient, they had performance status of 2, and 52% patient had performance status of 1. So both performance status patient, they were included. And on the right hand side of the panel, you can see that leptomeningeal metastasis was also present in these patients. 1.1% patient, they had symptomatic leptomeningeal metastasis, while 2.2% patient, they had asymptomatic
Hello, Manish sir. Hello, Manish sir. Manish sir, your
Manish,
voice
are
is
you
not.
there? I think Dr. Manish is trying to reconnect. We'll just wait for 2-3 minutes. Welcome back, sir.
sorry. Screen is My screen is visible. Hello.
Sir, now visible, sir. Now audible.
Screen is moving.
Sir, screen not visible, sir. Screen blank आ रहा है. Now visible, sir.
Now visible. Okay. I am audible also, na?
Yes, sir. Yes, sir.
Yes, sir, you are audible, sir.
So this was the primary endpoint, that is PFS. We discussed that the PFS was better in females. It was poorer in those patients who had malignant diffusion, and it was poorer in those patients who had liver metastasis. Also, those patients who had stage 4 disease, they had poorer prognosis. So treatment discontinuation profile. This was the treatment discontinuation profile. 14% patient they did not follow up. 16% patient they had other adverse event, and very important to see that 25% patient they had pneumonitis. So osimertinib causing 25% patient pneumonitis is a huge number which we should see while we treat our patients. And it also causes, as we have seen, the pneumonitis was the median duration of the onset was 56 days, grade 3 hematological toxicity 33 days, grade 3 non-hematological toxicity 53 days, QT interval prolongation to 30 days, and reduced ejection fraction 1 days. So these were the conclusion. Overall response rate was 76.2%. Disease control rate was 94.1%. Median TTF was 19.1 month. Median time with the start of the treatment to the onset of adverse event was 56 days. Pneumonitis of all grade occurred in 12.8% patient, and grade 3 or higher pneumonitis was seen in 4.5% patient. And the fatal pneumonitis also occurred in 4 patients, that is 0.7% patient. So the PFS after the first line osimertinib treatment in the real world practice was favorable, and the discontinuation rate due to adverse event was 18%, especially pneumonitis, which required further investigations. This is another study, real world study with a similar background. And this study, it started in April 1, 2018. The patient identification date was April 1, 2018. And then it continued till June 2020, when which the interim analysis was done, which was the cutoff date, and it is still being run. So the baseline clinical characteristic and demographic characteristic and the treatment, they were summarized using descriptive statistics. And there were 2 things which were used, that were real world time to new treatment or death. It was defined as the time from index date until the start of the next systematic therapy or death, and real world time to treatment discontinuation. This was time from index date until the earliest and the date of the osimertinib associated with the discontinuation or prior end of the first line therapy. This was the socio-demographic characteristics. These were the clinical characteristics. And the common EGFR mutation, exon 19, it was present in 51% patient, L858R, 33.7% patient, exon 19 deletion plus exon L858R was present in 0.7% patient. Both common and uncommon mutation, 4%. Uncommon mutations only 9.5% patient. And this was the treatment sequencing. 58% patient, they remained on the first line osimertinib therapy or were lost to follow up. 18% patient received second line treatment, which included PDL1 or PD1 inhibitor, monotherapy or in combination, EGFR TKI, mono or combination therapy, and the patient-based chemotherapy. And 18.4% patient, they died while on first line treatment, and 4.7% patient discontinued first line treatment. And you see the median follow-up time was 9.6 months, and real-world time to new treatment or death was 17.3 months. Total 37.2% event and 18.4% death, 18.8% switch to second line. This was real-world time to treatment discontinuation, 17.2 months, which is similar to the PFS which we achieved in the FLORA trial. And in the multivariate analysis, the following variable, they were significantly associated with real-world time to treatment discontinuation, that were Charlson comorbidity index more than 3, ECOG performance status more than 2, EGFR mutation type, and the number of metastatic site more than 4, or the evidence of liver metastasis. So the study provides the real-world insight on the patient on the first-line osimertinib, the real-world time to new treatment or death, or real-world time to treatment discontinuation results support the effectiveness of osimertinib in the real-world population, and the longer-term outcome will be validated in the final analysis. Thank you so much for your patient listening.
Thanks a lot, Dr. Manish, for this lovely presentation. So, are there any question from Dr. Manish? Anybody needs to ask anything? So, if there are no questions, so we can move ahead. So now I will be taking the next talk. So, topic of my presentation is why I choose osimertinib and the first line of therapy over other EGFR TKI. Okay. So good evening, everyone. So today I'll be talking about why I choose osimertinib as first choice in advanced lung cancer versus other targeted treatment. The session is sponsored by AstraZeneca and slides are provided by them. So if we look at the incidence of EGFR mutation and SCLC, so compared to Asia, rest of the world, in Asia and in particularly India, we see that the EGFR mutation rate is higher here. So in India, it is approximately 23 to 33% of the patient, that is one third of the total patient, while in further Eastern countries like Japan, Taiwan, and China, the incidence ranges from 35% to 40%. If we look all over the world, so incidence is roughly 15 to 20% of the patients, the least common being in the Middle East, where it is only approximately 10% of the patient. So in Asia and Indian population, we see that the EGFR mutation is much higher in comparison. So that is how the treatment of EGFR mutated NSCLC has evolved over time. So in 1997, that was the first time when the EGFR inhibitors were tested, and they were found to be effective compared to the platinum-based doublet agent, and they entered clinical development. 2004 was the time when the EGFR mutation sensitive to erlotinib and gefitinib discovered in lung adenocarcinoma. In 2009, the mutation testing was included in the diagnostic workup after the IPASS trial, which showed that the first-line gefitinib was better than chemotherapy. In 2010, we had optimal trial where erlotinib was also better than chemotherapy. So in 2009 or 10, the erlotinib and gefitinib became our first line of therapy. Either of these options can be taken compared to chemotherapy. In 2013, the second line EGFR TKIs like afatinib came into the picture after the Lux Lung 3 and 6 trial, where afatinib was shown to be better than chemotherapy. In 2017, Aura trial came, which showed that the osimertinib was better than chemotherapy in treating patients in the second line who have developed EGFR T790M mutation. So with the Aura trial, osimertinib got approved in the second line. Also at the same time, the Archer 1050 trial came out, which showed that the first line dacometinib was better than gefitinib. So there was no head-to-head comparison between osimertinib and dacometinib, but the cross-trial comparison showed that the osimertinib was better than dacometinib. However, both were better than the first line EGFR inhibitor. In 2018, So dacometinib and osimertinib both were approved at the first-line chemotherapy. However, when the FLORA trial came in 2018, the first-line osimertinib was found to be significantly better than first-generation TKI. Now, switch back to 2024. Now we have FLORA-2 data where we see that the osimertinib along with chemotherapy is superior to osimertinib alone, and that is likely to become the next standard of care therapy in the coming year. So if we look at the current treatment option for EGFR mutated advanced NSCLC, the first generation TKI like geftinib and erlotinib are an option. They do reversible inhibition. Mostly we are using them in patients who cannot afford osimertinib. Second generation TKIs like afatinib and dacometinib, so they are also got irreversible inhibition of EGFR, and they are usually selected, particularly afatinib, in rare EGFR mutation, which are not usually targeted by osimertinib or geftinib or erlotinib. Next, we have the third line TKI like osimertinib, which is approved in all first line as first line therapy of all EGFR mutated lung cancer, and also second line therapy in those patients in whom T790M mutation is found. It also works by causing irreversible inhibition of EGFR target. So if we look at the outcome with first and second generation TKI, if we look at the geftinib and erlotinib data, so for geftinib we have IPASS trial, first signal trial, NEJ GSG002 trial, and WJ-TOG 3405 trial. So all of them, if we compare all of them, so these trials have in the control arm, they had progression-free survival between 5 to 6 months, and with the inclusion of geftinib, the survival median PFS increased to 9 to 10 months, so which was significant. If we look at the erlotinib, where we had optimal and ensure trial, where the median PFS increased to 13.1 months, which in optimal trial, while 9.7 to 10 months in other trials. If we look at afatinib, so there were Lux Lung 6 trial, which showed that the median PFS was further increased to 11 months to 13 months, and dacometinib, this figure increased to 14 months. So majority of the patient treated with EGFR TKI ultimately progress with an average PFS of 8 to 14 months, 8 to 9 months being on the first line TKIs, and by 12 to 14 months being with the second line TKI. So head-on trial of first and second generation TKI we have. So Lux Lung 7 trial of afatinib, which compared it with the geftinib, which with the ORR was 70% with afatinib versus only 56% with the geftinib arm, and the median PFS 11.0 versus 10.9, which is somehow found to be statistically significant. But median OS was also improved by approximately 3 months. If we look at the Archer 1050 trial, which compared dacometinib with geftinib, we saw that the ORR is also 75% versus 72%. Median PFS was 14.7 months versus 9.2 months. Median OS was significantly rose from 26.8 months to 34.1 months, which is statistically significant. We saw that second generation TKI improved the survival outcomes compared to first line TKI, that is geftinib. If we look at outcome with the osimertinib, that is the FLORA trial, here we see that the curves are separating nicely from the beginning itself, with the EGFR TKI giving median PFS of 10.2 months. Compared to that, osimertinib gave a median PFS of 18.9 months. The hazard ratio being 0.46 with a confidence interval of 0.37 to 0.57, which is very, very significant. Even after the follow-up of 2 years, we see that this difference is maintained. If we look at the forest plot of this trial, we see irrespective of sex, age, race, smoking history, presence of CNS metastasis, performance status, and EGFR mutation, benefit is maintained across all subgroups. CNS metastasis, stable CNS metastasis were also allowed in this trial. So if we look at the OS data, so now we have 4-year data of overall survival. We see that the survival advantage is maintained, with the median overall survival being 38.6 months compared to only 32 months with the EGFR TKI comparator arm, with hazard ratio of 0.80, which is just sort of statistical significance. So trial which seemed to improve initially, later on seem to merge, but still they are still separated. If we look at the forest plot in most of the subgroups, this significance is maintained. What is more striking is that a significant number of patients continue to remain on therapy even after 3 years. So if we look at after the end of 3 years in the continuation arm, control arm, only 9% patients were continuing of geftinib, while in the osimertinib arm, 28% patient had continued. To receive osimertinib, that was 70% after the end of 1 year. And time to first subsequent therapy in the osimertinib arm was 25.5 months. That was only 13.7 months in the EGFR TKI arm with a hazard ratio of 0.47, which is statistically significant. Now coming to the next point of discussion, that is relevance of CNS metastasis in advanced NSCLC patient. We are well aware that NSCLC is a very common cause of brain metastasis, and lots of patients actually develop brain metastasis either at the baseline presentation or sometime along the course of therapy. So patients with brain metastasis have a significant decrease in quality of life, and this is very well established. And if we see a EQ5D score for NSCLC patient with a single metastatic site, we see that the quality of life decreases a lot in the brain metastasis. 0.52 is the score remaining, is the least deteriorated with the adrenal gland metastasis. And patient with a single brain metastasis experience the greatest decline in quality of life compared to other site of metastasis. If we look at the algorithm to manage a patient with EGFR mutated NSCLC along with CNS metastasis, if we see if the brain metastases are symptomatic, then we have to give some kind of local therapy like stereotactic radiosurgery or surgery. If there is no symptomatic and brain metastasis is just incidentally found out on MRI imaging, that we can straight away go for osimertinib without having to resort to local therapy. If there is progression first or second generation EGFR TKI, which might have happened due to non-affordability, and if patient has brain PD and that is symptomatic, we have to resort to the local therapy. If it is not symptomatic and we have only CNS PD, then we send for T790M mutation study. If it's positive, we switch to osimertinib. If it's negative, then we have to go for local therapy and we do continue the TKI. If there are CNS, if it is not symptomatic and CNS and systematic PD both happen, then we test for T790M mutation. If it is positive, then we switch to osimertinib. But if it is negative, so we go for local therapy and then we give chemotherapy. Pardon me. So there is a problem in the slide. So it is symptomatically supposed to be yes. So if it is symptomatic, then we go to the chemotherapy if T790M mutation is negative. So it has shown a significant brain penetration in preclinical models. So that is the preclinical model where we see more the uptake, that is the red orange area, there the osimertinib uptake is higher. So better brain penetration will observe with osimertinib and compared to other TKIs in preclinical studies. So similar penetration was seen in the human study as well. So if we look at the MRI and metabolic scans of 8 different subjects, we see that individual regional distribution of osimertinib is shown, and it has good brain penetration and the concentration has increased over number of days. In FLORA trial, a significant PFS benefit was seen irrespective of the CNS disease. If we look at the patient who had known or treated CNS metastasis, which was 116 patients, which is a good sizable number of patients, here PFS was obviously worse compared to those who did not have CNS metastasis, but osimertinib improved the PFS nevertheless. It was 15.2 months compared to only 9.6 months in the EGFR TKI comparator arm with hazard ratio of 0.47, which is statistically significant. If we look at the subset who do not have a CNS metastasis at the baseline, the osimertinib fared well in this population as well, with the EGFR TKI comparator arm having a very less median PFS comparatively with a hazard ratio of 0.46. CNS progression events occurred in 6% of the patient receiving osimertinib, while they happened in 15% of the patient receiving EGFR TKI comparator. If we look at the waterfall plot, so according to the on the left side we have osimertinib arm, and on the right side we have EGFR TKI comparator arm. If we see that the median best percentage from the baseline in CNS target lesion was 64% change, while in the comparator arm it was only 45% change from the baseline, and stable disease for also only 1, and most of the patient had actually responded well. So majority of the patient on osimertinib had partial response along with complete responses in few patients, while none such thing was seen in the comparator arm. Fewer CNS progression events were seen in the FLORA trial. So in the osimertinib arm, only 12 patients had CNS progression other than death, while it was 26 in EGFR TKI arm. If we look at Progression due to new CNS lesion, it was only in 7 patients with the osimertinib arm, while it was 20 patients in EGFR TKI comparator arm. CNS disease progression were mostly driven by new CNS lesions, and fewer patients experienced CNS progression, and fewer patients progressed due to new CNS lesion with osimertinib treatment compared to EGFR TKI arm. Now coming to the next topic, that is treating a patient with EGFR mutation and high PD-L1 expression. So a 57-year-old female diagnosed with stage 4 adenocarcinoma of lung with comorbid condition of hypertension. Metastatic sites include right upper lobe, liver, and mediastinal lymph node, that is metastatic disease at the baseline. Symptoms being cough, dyspnea, anorexia, weight loss. ECOG performance status 1, EGFR exon 19 deletion mutation was found, and the PD-L1 expression was found to be 55%. Should the treatment option be EGFR TKI or immunotherapy? So we have done analysis of FLORA trial in patient with PD-L1 expression. So in PD-L1 expression more than 1%, we see that there's a good benefit of osimertinib with the EGFR TKI comparator arm had PFS of only 7 months compared to osimertinib, which had 18.4 months with a hazard ratio of 0.30. While if we look at the same data in PD-L1 negative subset, so the hazard ratio of 0.37 with the comparator arm having a median PFS of 11 months compared to 19 months in the osimertinib arm. And if PD-L1 unknown, the hazard ratio was 0.49, so that is 10.8 months versus 19.1 months. What do these data tell us? That irrespective of PD-L1 expression, the osimertinib is nonetheless effective. So if we look at immunotherapy in patient who had EGFR mutated patient, inferior clinical efficacy is observed with immuno-oncology drugs in EGFR mutated NSCLC patient, and now this has come to our notice, and it is very well oncologists across the globe are aware that not to use immuno-oncology drugs in patient who had EGFR driver mutation positive. So we had atezolizumab, that is a PD-L1 inhibitor, in which OAK phase 3 trial, no OS benefit from atezolizumab over docetaxel in EGFR mutant patient. For nivolumab, we had Checkmate 057 trial, in which median OS in nivolumab group versus docetaxel group. EGFR mutated patient did not have any PFS or OS benefit. In pembrolizumab, Keynote 010, no OS benefit from pembrolizumab over docetaxel in EGFR mutant variant. Also in pembrolizumab phase 2 trial, the efficacy of pembrolizumab was evaluated. None of the patients with EGFR mutant NSCLC responded to pembrolizumab. Enrollment was ceased due to lack of efficacy. Putting all these 4 trials into picture, we can safely say that immuno-oncology drugs do not work in EGFR mutated subset of the patient. If we look at the guidelines on management of such patient, that is NCCN guidelines 2024, they say that although PD-L1 expression can be elevated in patient with an oncogenic driver, targeted therapy for the oncogenic driver should take precedence over treatment with the immune checkpoint inhibitor. So it is enough to say that here that immuno-oncology drugs should not be used in patients who have driver mutation positivity. Coming to the next topic, that is maintaining quality of life in advanced NSCLC patients. So better patient-related quality of life. So we have a QLQ-C30 global health status, physical functioning and social functioning improved in the both treatment arms. None of the improvements were clinically relevant, however, because improvement in emotional and social functioning was significantly greater with osimertinib than with EGFR TKI comparator arm. Cognitive functioning remained stable with osimertinib arm, but it deteriorated in the EGFR TKI comparator arm. If we look in this picture, we see that the osimertinib arm, the global health status, physical functioning, and role functioning, everything improved. While if we look at the EGFR TKI arm, cognitive functioning actually declined. So improvement in the symptoms, cough, dyspnea, chest pain, fatigue, and appetite loss. In almost all of these factors, osimertinib was better than EGFR TKI, except for appetite loss, where there was non-significant difference in favor of EGFR TKI comparator. So osimertinib is safe to use. If we look at the safety data, in the FLORA trial, LUX-Lung and ARCHER trial, so rash or acne, most common with dacomitinib, that is 14% of the patient. With osimertinib, it is only 1%. If we look at paronychia, similar situation. If we look at diarrhea, and afatinib is toxic, 13.1% patient, while only 3% patient in the FLORA trial had diarrhea. Stomatitis, only 1% of the patient. It was 4.4% in the LUX-Lung 7 trial. In ARCHER trial, it was 3.5%. Dose reduction were required only 4% of the patient in the flora, having useful to say that almost all of the patient had good clinical response and they could continue with osimertinib in their usual dose, while afatinib had to be reduced in 42% of the patients due to side effects, while almost two-thirds of the patient needed a dose reduction with dacometinib. To summarize, with the use of osimertinib compared to geftinib and erlotinib, it improves PFS, it improves quality of life, it improves OS as well. Toxicity is less and it has good CNS penetration. The closest, most efficacious drug is dacometinib, which has been compared with geftinib, although QOL data is pending. OS is improved, but not up to that extent, and CNS penetration is there, but it is not that extent. Also, it is much more toxic compared to osimertinib. If we have data with geftinib plus platinum-based chemotherapy, which has been combined with the geftinib, so we do not have any data about quality of life. Toxicity is also higher. It is a difficult regime to treat, as Dr. Nitin already mentioned, and CNS metastasis patients were excluded in these trials. If we look at erlotinib and bevacizumab, that has been compared with erlotinib, the PFS is improved, quality of life is not assessed, OS is similar, toxicity is high, and CNS is no penetration is there. Afatinib is the one where CNS penetration is there, although quality of life does not improve and toxicity is very high. Geftinib and erlotinib, both of which are generation 1, first generation TKI, we have been compared with platinum-based chemotherapy where PFS is improved. Quality of life is also improved. CNS penetration, very mild CNS penetration is there, and they are toxic also. So osimertinib should be first choice in EGFR mutated NSCLC patient. It has shown maximum PFS and OS benefit. Osimertinib has better CNS penetration, hence it is not only treating CNS mets but also protects against CNS metastasis. Osimertinib is a molecule with least toxicity, hence patient have good quality of life. So that's all. Thank you for your patient listening. If there are any questions, so I'm happy to take them. So I think if there are no questions, we can conclude the session. So for the concluding remark, I would like to say that it was a pleasure to host such symposium. As we know that the treatment of NSCLC has been undergoing radical changes, and it is imperative for us oncologists to be updated about these changes so as we can provide the best treatment possible to our patients. Symposium like these are a much needed step toward that direction. And it was a lovely discussion, and we discussed with each other, and we came to common some agreements were there, some disagreements were there. But in the end, um, so it was a good and fruitful discussion. So I have a question from Sagar Saha. So he had asked some major toxicity we see with osimertinib. So with osimertinib is actually a very safe drug. So toxicities are almost next to nil. We do not have much toxicity, although in literature they say that some patient may have uh, skin rashes, so that is seen. One of my patient had hyperkalemia, that is described, and as soon as we reduce the dose, the hyperkalemia also improved. One of the real world study that Dr. Manish presented, so approximately 7 to 8% patient had interstitial pneumonitis, although I have not seen that autoimmune pneumonitis happening in any of the patient, and we have had this discussion with other doctors also in such forums, and they have also not seen pneumonitis in their clinical practice. Rashes, skin rashes are the only toxicity they have been seen. The dose of osimertinib to be used with 80 mg once a day, so it can be taken with or without food. That is only thing. So 80 mg OD is the dose. And usually the dose reduction is not required, so it is a safe drug. So we have been using it for quite some years now, and we are comfortable using this. So QTC, we should not be worried. See, QTC, of course, that is described. So at the baseline, when we start the osimertinib, then we do get CBC, LFT, KFT, all the electrolytes, ECG, echo, everything we do. But usually, unless patient is symptomatic, so that is not something that we routinely prescribe. So, but in rare cases, if QTC is prolonged, then definitely dose reduction or interruption is required. Also, the serum magnesium, serum calcium, and serum potassium also have to be checked. As I already told that one of my patient had hyperkalemia. So after the electrolyte correction, so if we are certain that it is because of the osimertinib, that dose interruption or dose reduction may be required. How to target osimertinib resistance? So osimertinib resistance happens most, there are various mechanisms. So sometimes EGFR bypass mutations happen, sometimes secondary mutation happen in the EGFR, and then MET amplification, MET amplification. So that is also one of the reasons. Now we do have facility to measure, to actually detect what is the exact cause of resistance, although the techniques of such resistance mechanism are not widely available and they are not very much popular. So usually we tackle these cases with the chemotherapy only, and so we do not switch to any other TKI. And in those cases, we continue with the chemotherapy only. So I hope that answers your question. So Mr. Sagar Saha asking the cost of osimertinib. So we have osimertinib is the patented product of AstraZeneca. No biosimilar is available at this point of time. So they have a good patient access program where they provide, I think, 1+1 or 1+3 dose are free. Compounding with the patient access program, so the cost comes to approximately 1,20,000 for 1 month of therapy. Including patient access program. After the patient access program, this is the cost. So it is costly, and but then AstraZeneca, I'm sure in future will have more better patient access program, and it will become more affordable. Thanks a lot. So if there are no other questions, so let's just conclude the session. It was a lovely talk. Thank you all for being there. Over to you, organizers.
Thank you, Dr. Kapil Goel, sir. Thank you, everyone, for giving wonderful talk on given topics. Good night, everyone.
Good night, everyone.
Technical